FFA.
Good morning all. Thank you, madam. And we'll start with Fundus fluorescein angiography. It works in the principle of fluorescence by the sodium fluorescein, and 5 ml of 25% sodium fluorescein is injected, and this has high rate of anaphylaxis, so we should be careful during the procedure, and as it is done with the light off in a dark room, during the process of the procedure, we should be alert to find out any of the allergy anaphylaxis. Otherwise, we can lose the patient. So all the facilities for resuscitation should be available, and the personnel who are doing it should be able to handle the procedure in case needed. And there is an excitation filter and a barrier filter. Coming to the phase of angiogram, first is the choroidal phase or pre-arterial phase with the flush, which happens 10 to 12 seconds after the injection of the dye, followed by arterial phase, and the venous phase with the laminar airflow and complete venous filling, and the recirculation phase. From here, the intensity of the fluorescein start decreasing. Coming to recirculation phase, the dye is gradually eliminated from the eye. And the timing is important. Anything more than 30 seconds in arm to choroid is abnormal, and anything more than 5 seconds in the arterial phase is delayed, and arteriovenous transit more than 15 seconds is abnormal. Autofluorescence can be emitted by certain structures in the eye, like optic nerve drusen and hamartomas, and the pre-injection photograph can show these, and pseudofluorescence can happen due to the mismatch of filters. Abnormal fluorescence can be either hyperfluorescence or hyperfluorescence. The hyperfluorescence can be block fluorescence from a preretinal source of a preretinal heme or subretinal heme, or a filling defect from a major artery occlusion, or patchy filling defects in various conditions. Hyperfluorescence can be window defects, which will start in the early phase, and gradually it will decrease in intensity, but the size will remain same throughout the angiogram. And pooling will start in the early phase and increase in intensity, but the size remains same. And leakage will increase in intensity as well as the size as the phases of angiogram progresses. And staining happens at the late phase, and here we can see the transmission defect through the RPE, the staining of the sclera. Coming to CNVM, and the parafoveal capillary branch network of hyperfluorescence starts early in the angiogram, which keeps increasing in intensity and leaks at the late phase. If there is a large PED with irregular filling, we should suspect of an occult CNVM, which has to be confirmed with an OCT or an ICG. We are not talking about ICG because not included in the topic. In central serous chorioretinopathy, there can be leaks in blot or smokestack, which progressively increasing in size and intensity throughout the angiogram. And there is an RPE tract of transmission defect, which will keep decreasing in intensity as the phase of angiogram progress. The diabetes is a common disease. It can present with maculopathy or proliferative retinopathy. The focal maculopathy is characterized by leaking microaneurysms starting in early phase, and by angiogram we can identify the leaking microaneurysm which will need treatment, and focal laser is needed to treat these, and or it can be a diffuse leak due to the leak from the parafoveal capillary bed or a cystoid petaloid pattern. And when there is a loss of perifoveal capillary network, it will be an ischemic maculopathy. We can see the loss of perifoveal capillary network. And in proliferative retinopathy, it can be an NBE or NVD, which progressively increase in size and intensity of leak. You can see the asymmetry of effect of the retinopathy in the right and left eye. Right eye, there is an early NBE, whereas left eye is advanced diabetic disease. In CRVO, there is dilatation and tortuosity of veins with delayed AV transit time, which is about 34 seconds. And in late phase, there is staining of the vessel wall and this staining. This is a non-ischemic CRVO. And there is a cystoid macular edema in a honeycomb pattern. And ischemic CRVO, there is a capillary non-perfusion in all the quadrants with the loss of perifoveal capillary network. And the tributary vein occlusion, which is not affecting the macula. There is blockage of the fluorescence. And so ischemic branch retinal vein occlusion, whereas the infratemporal vein is occluded with the capillary non-perfusion and appearance of NVEs. And there is a profuse leak from the NVEs. Retinal macroaneurysms are not very common, but it can happen in ladies of third to fourth decade, and which happens in the first to third order vessel, and which causes leak from the early phase of the angiogram and progressively increasing size and intensity. So while reporting an FFA, we need to see first the fundus photograph, identify the eye, and note the arm retinal circulation time, whether there is any delay in that, and note the AV transit time, and identify the phase of angiogram, and identify the type of abnormality, whether it's a hypofluorescence and hyperfluorescence, and we need to go through the early, intermediate, and late stage of the angiogram to know the type of abnormality. Coming to ultrasound, it works with the principle of piezoelectric crystal in a transducer which emits the sound wave at 8 megahertz, which is usually used in ultrasound. We use 20 megahertz from UBM. And there is a transducer, amplifier, and a display monitor. And if the sound wave is falling on the structure perpendicularly, the returning echoes are stronger. And the gain is measured in decibels, and by increasing or decreasing the gain, it decreases the increase of the amplitude or brightness of the echoes. And the time gain compensation enhances the echoes from the deeper structure by inhibiting the echoes from the superficial structure. So that gives a better quality of the structure which we image. And it can be an A scan, which is one-dimensional amplitude modulated, or a two-dimensional B scan displayed in the monitor. So the probe position can be either transverse, longitudinal, or axial. The transverse will measure the lateral extent of the lesion. Longitudinal measure the antero-posterior extent of the lesion. The axial A scan, B scan gives the lesion in relation to the lens as well as the optic nerve head. And we need to take all these scans, longitudinal, axial, and transverse, both in the high and low gain. And we need to measure, identify the location, extent, and size, and we need to know the movement, vascularity, and convention pattern of the lesion. In a normal B scan, in young age, the lens is ecolucent, but as the age progresses, once the cataract happens, there is change in intensity of the lens, and vitreous in normal, in young ages, ecolucent. Retina choroid and sclera is highly reflective, and optic nerve is wedge-shaped, acoustic void in the retrobulbar region. So coming to PVD, this is a membranous echo. We are dealing with either a dot echo, membranous echo, or a solid lesion or a cystic lesion. So in PVD, it's a membranous echo which can be complete or incomplete PVD, which is appearing in the low gain, disappears in low gain, and then it's linear and with an undulating movement. And vitreous hemorrhage is characterized by multiple dot-like echoes throughout the vitreous cavity. It can be either an acute or a fresh vitreous hemorrhage or a long-standing vitreous hemorrhage. And in long-standing vitreous hemorrhage, it is more of a clumps and pseudomembranes, and which is gravity dependent. And the differential diagnosis of this is a hasteroid hyalosis, which is more reflective, discrete echoes, and with a definite gap between the posterior surface of this lesion and the anterior surface of the retina. And sometimes this asteroid hyalosis is associated with the subhyaloid heme, which will show the low to moderate reflective echoes. And another differential diagnosis is endophthalmitis. There is a comparison between the normal eye and an endophthalmic eye. There is a membranous lesion and moderate reflective echoes, and there is thickening of the retina and the choroid and the sclera, and it may be associated with the other signs of retinal detachment and choroidal detachment. Sometimes there can be an intraocular foreign body or a dropped lens material. So retinal detachment is a high reflective membrane which with an attachment to the optic nerve with the movement, and it can be a complete or a partial detachment, and long-standing retinal detachment can have cyst formation with a decreased mobility. So it can be a closed funnel or an open funnel retinal detachment. And the exudative RD is the fluid dependent, and it has a changing configuration and usually appears as a convex lesion in supine position, and it disappears on sitting position due to the shifting fluid. And the causes can be varied from inflammation to tumor, mass, or granuloma. Tractional retinal detachment will have attachment to optic nerve, which may be point attachment or a broad base attachment. Sometimes the choroidal detachment may be associated with the retinal detachment. Choroidal detachment usually is a hyperreflective double spike, M spike lesion from the retina as well as the choroid, and it may be a serous choroidal detachment or a hemorrhagic. If it is hemorrhagic, there will be low reflective echoes behind that. You can see both the echoes of the retinal detachment as well as the choroidal detachment. And you can see here there is a retinal detachment and the PVD in a acute RD, and this in a long-standing RD. The movement of the retina is very limited, whereas in a fresh RD, it is freely mobile. And few conditions of retinochoroidal elevation like PCV and macular edema, CNVM, tuberculoma, or tumors. You can see the with heme near the retinochoroidal elevation, which is moving with a low intensity echoes. And coming to solid lesions, we have retinoblastoma, which is of two types, exophytic and endophytic. And endophytic, which grows into the vitreous cavity, which is high reflective and with the vitreous seeding and with multiple high reflective echoes due to the calcium, or a endophytic tumor. And then in the exophytic, there is a exudative retinal detachment and a subretinal mass. And choroidal melanoma, it's a solid lesion and with a high surface reflectivity with a mild to moderate internal reflectivity, and there is an acoustic hollowing behind that, and there is an angle of kappa. Angle of kappa is when we draw a line from the maximum spike of the A scan and the succeeding spike, it is steep. And this shows there is decrease in intensity of the sound which is traveling. There is a mass lesion which is characteristic of malignant melanoma. So angle kappa, acoustic hollowing, and a solid tumor with a high surface reflectivity with a mild to moderate internal reflectivity is diagnostic of choroidal melanoma with the choroidal excavation. You can see the choroid here well, but it is obliterated due to the mass lesion. And posterior scleritis, and there is thickening of the choroid as well as sclera, and subtenon space is expanded. This is a T sign. And the intraocular foreign body, you can see there is a high reflectivity of a metallic foreign body in these two. So ultrasound is one of the most important non-invasive diagnostic method which needs very minimal patient cooperation, and the echogenic characteristics are diagnostic of the disease, and correlation with the history and clinical examination is most important. Thank you.